But over the weekend, my 18-month broke his tibia and fibula. And so he's in a cast. He cannot put like any weight on his leg or anything like that. And then I also have a 3-year-old who's really wild. So I'm having to like really make sure I'm watching her not jumping on his leg, and then also making sure he doesn't try to get up and walk on it. And my husband actually had to go into work today, and he told me he was going to be later getting home. So I had to wait till he got home to be able to watch my little boy to make sure that he doesn't get up on his leg. So again, I apologize for that, but hopefully we should not have to change any more dates after that. Got somebody else coming in. Just a second. Okay. So this week we are testing on, and you've been learning about postpartum and then postpartum complications. Labor is super, super important, obviously, but postpartum is very, very important as well, because it's a very crucial time period for a lot of things to happen for moms. So there's a lot of things that can go wrong. And there's a lot of things that we have to really use our assessment skills and be very sharp on those to ensure that we are really making sure the patient is okay. After we have the baby, we have our fundus obviously in our uterus. That's going to eventually start to shift back down to the point to where it's going to tuck back in behind our pelvic bone, and we're eventually not going to be able to feel it anymore. So at 1 hour after delivery, your fundus should be even with the umbilicus, okay? So 1 hour after delivery, the fundus should be even with the umbilicus. After that, it's going to start descending 1 centimeter or 1 finger breadth. If you're feeling it, it should be 1 finger breadth per day. And then usually by day 10, like I said, it's not going to be palpable anymore, and it should be tucked back up and under that pelvic bone. So 1 hour, it's at the level of the umbilicus. And then after that, it's 1 centimeter or 1 finger breadth per day. And by day 10, it's usually gone. Okay. So we know that estrogen and progesterone play really big roles. Those hormones play really big roles during pregnancy. So after we have the baby and after we have the placenta, estrogen and progesterone levels are going to go from super high to super, super low. So they're going to drop pretty significantly. And when they drop significantly, that is what causes our uterus to shrink back to that normal non-pregnant state. So estrogen and progesterone are responsible for the uterus shrinking back to the non-pregnant state. Okay. All right. So we're going to go over postpartum care in general here. And then we'll kind of talk about some really important things that we have to worry about during postpartum. This is a lot because I'm going to go through, since I'm not teaching you, I would feel better if I went through everything with you just kind of really quickly on how to assess your patient, what everything is, and what you're looking for. So if at any point I'm going too fast or you do not understand something and you want me to slow down and explain it better, please just like raise your hand, because sometimes I don't look at the chats because I'm looking at my notes, and let me know. So first thing with postpartum care, obviously we have to check the fundus, right? So this is a super important part. When you are assessing a fundus, you never only want to use one hand and just palpate the fundus. You have to put one hand on the top of the fundus and one hand right at the symphysis pubic bone. This is helping to support the uterus while you are massaging up top to feel the fundus. If you do not put one hand at the symphysis pubic bone while you're palpating the fundus, you can cause the uterus to invert, and that is an emergency. They'll have to go downstairs. They will have to have surgery to get their uterus put back into place, and it can also cause hemorrhaging, okay? So make sure anytime you're palpating a fundus, you have one hand on the top of the fundus, one hand at the symphysis pubic bone, and you're holding that down there, okay? Now, when we are massaging a fundus, we do not push to their backbone. That can cause hemorrhaging itself. You just very ever so slightly massage to where you can feel the fundus. And as long as you can feel it, you note where you feel it at, and that's good enough. Okay. You don't have to push down super hard, like I said, to their backbone. You want the fundus to be firm and not boggy. If it's boggy, then it's not contracting like it's supposed to. That can lead to a hemorrhage. Okay. So you want it to be firm and you want it to be midline. So when I say midline, think if you draw a line right through your body all the way down through your belly button. That's midline. You don't want it to be the left, to the right, anything displaced. Firm and midline. If for some reason you notice that your patient, when you're palpating their fundus, has a boggy fundus and it is placed like displaced somewhere to the left, to the right, something, um, then you can give them the massage. Okay. With the massage, you do have to push a little bit harder than you do when you're just normally palpating. You still do not have to push to their spine. Point being, if they are not hemorrhaging and they're kind of trying to start hemorrhaging and you push super, super hard, they may have some sort of a clot that is stuck to the inside of their uterine wall somewhere. And that clot may be the only thing that is keeping your patient from hemorrhaging. And if you push super hard with enough force, you may dislodge that blood clot and may come out of the vagina and they may start hemorrhaging worse. So just give a nice little rub vigorously, but not hard, hard. Okay. Now, while we're doing our fundal massage, we want to be looking at our lochia, right? So we're going to look down there at the perineum area and see what type of lochia that we have. So you should have learned about three types: lochia rubra, serosa, and alba. Lochia rubra is the blood that you're going to see in your immediate postpartum period. That's dark red blood. That is perfectly normal. Lochia serosa is a lighter pink tinge color. So it's still going to be bloody, but it's not going to be dark red. It's going to be more of like a pinky tinge. Lochia alba, this is the last step before you go back to not bleeding at all. Okay. So this kind of is like a lighter yellow discharge color, not completely white like normal discharge, but it'll be a little bit yellowy tinged because that blood's finally trying to exit all the way out. Now, very important with lochia. You start off with lochia rubra, you end with lochia alba. If at any point, let's say you have progressed to lochia serosa after your postpartum period, if for some reason your patient goes home and they call you and they say, hey, I had a really light pink tinged color blood, but now it's gone back to really dark red, then you're going to say, hey, that's not okay. You need to come back to the hospital because they may be trying to hemorrhage. Okay. Okay. When we're looking at our lochia, we also do not want to just look at the color. We also want to look at the amount. So you're going to assess the amount on a pad. Is it scant, which is 2.5 centimeters on a pad? Is it light, which is less than 10 centimeters on a pad? Moderate, which is less than 15 centimeters on a pad? Or is it heavy, which means that a whole peri pad has been saturated in 1 hour? And this is the assessment that you're going to do every single time when you do an assessment on a patient postpartum. You're going to grade the lochia, the amount of the lochia, all of that. Okay. Within the first hour, of your patient delivering, it is okay if they saturate one pad. Once you get out of that first hour, your patient should not saturate one pad within an hour or more. Okay. That is worrisome. Excuse me. You would report that and let your provider know. So if it is in the immediate postpartum period within 1 hour, that is okay. Outside of the 1 hour mark, that is not okay. Now, vital signs in the postpartum period. So your first hour after delivery, you're going to do vital signs every 15 minutes. With those vital signs, you're going to palpate the fundus. You're going to note the lochia, the amount of the lochia. Okay. And then also when you're looking at lochia, you're wanting to make sure that you turn your patient to the side if they're unable to move still, if they've had an epidural. and look underneath their bottom because, like I said last week, sometimes if they're laying back, that blood can pull up under their bottom, and you may not be able to see it. It may not be visible unless you roll the patient over. So that's super important as well. Okay. Another assessment that you will do in the postpartum period goes along with the mnemonic bubble LE. So it's breast, uterus, bladder, bowel, lochia, episiotomy and laceration, and then LE is legs and emotion. So, um, for this assessment, you're not necessarily doing most of these within the first hour. This is more for your postpartum period in general while they're still in the hospital. So for your breasts, you're always going to inspect first. So you'll look at them, you make sure they don't have any streaks, which could indicate mastitis. In your immediate postpartum period, you're more than likely not going to have mastitis, so you don't have to worry about that. Usually that sets up once they've gone home, but you still want to inspect and make sure. If they're breastfeeding, also, you want to make sure that they do not have any hickeys on their breasts or cracked nipples or really, really reddened areas around the areola or the nipple. That can indicate that the baby may not have a good latch, which that's something that we definitely have to fix. Um, if the baby does not have a good latch, number one, it's not going to get a good milk transfer. So it's not going to get fed, right? And then also, the more milk that the baby takes out, the more the body produces. So it's also going to impede the mom's milk flow. That's called milk stasis when the milk is not being effectively removed from the breast. That can set up mastitis. So if you think about it, you have this big milk duct in there, and it just keeps getting fuller and fuller and fuller, and no milk is getting removed. So it's getting really angry and engorged. And it can eventually set up mastitis because it's just keep getting inflamed and inflamed. You also want to educate your patient to wear a good supporting bra as the milk comes in. And that's about all for the breasts. For the uterus, you want to tell them that some cramping can be expected, especially if they are breastfeeding. Um, because when you breastfeed and the baby pulls the nipple or tugs on the nipple, it sends signals to your brain that tells your brain to release natural oxytocin. And as you've learned through your lessons this week, oxytocin is what causes the cramping of the uterus. So, some cramping can be normal, especially if they're breastfeeding, but you should never have a tender uterus. So, if you're palpating and your patient's about to come up out of the bed, then that is not good. That is an indication that something is going on. They may be developing endometriosis or something like that. Bladder. So, when you're doing your fundus palpation, you always want to palpate to see if you can feel the bladder. You should not feel the bladder. If you do feel the bladder, then it is distended, and you're going to tell your patient if they're able to walk, let's go try to urinate because the way that the bladder is positioned around the uterus, especially whenever you're pregnant or right after delivery, the bladder can actually, once it gets bigger and bigger and bigger and distended, can displace the uterus. So it's not midline anymore. And if that happens, then it's going to become boggy. And a full bladder can actually cause your patient to hemorrhage. Okay. So if you feel and palpate the bladder, then you're going to say, hey, let's go to the bathroom. Let's try to urinate really quick. If your patient is unable to urinate, then your provider may order um, a bladder scan first, possibly. Some of them may say, hey, just go ahead and give a straight cath and let's go ahead and empty the bladder so we can take care of the problem right now. And then encourage fluids to try to help the person pee on their own afterwards. And then you also want to discuss proper care after delivery with your patient when they do urinate. Make sure that they are using that peri bottle and really squeezing water all over their perineum area to clean it off really well. And then make sure if they're using the tissue paper to wipe that they're not wiping and tugging, they're just blotting to get it dry because number one, you don't want tissue paper fragments stuck in there, especially if you have a laceration, but it's also probably a little bit sore as well. You can also tell them to put Tux pads and spray the Dermaplast spray to help with burning and a little bit of pain down there. And then changing their pad and making sure that they're keeping that clean. Bowels. So obviously you're going to ask them, they need to poop before they go home. So you need to ask them if they've had a bowel movement. Um, C-section patients, obviously this is a med-surg thing, but if they've had a lot of anesthesia, we know that sometimes the bowels are the last to wake up, right? So they may take a little bit longer to have a bowel movement after they've had a C-section, and that's okay. Lochia, that's the L in the bubble LE. We've already talked about that, so we're not going to go back over it. The next is episiotomy and laceration. So sometimes they can have a tear and it does not have to be repaired. And then sometimes they have an episiotomy or a pretty big tear and it does have to be repaired. So we always want to make sure that we're inspecting those and noting them on our assessment. We'll have our patient lay on their left side and they're going to bring their knees up and forward. This just kind of gives us like a better view of the entire perineum so we can see what's going on. You want to look for bruising, erythema, edema, and then if the laceration is repaired, does the laceration look okay? Make sure that it's not like trying to come undone, and then also make sure that it doesn't look like it's getting infected if they have to stay there a couple days. Another big thing that you want to look for is hematoma formation. So sometimes, even if they do not have any sort of laceration or anything, and they have pushed for a really long time and the perineum has stretched super, super far, they can get a hematoma there. And we'll talk in a little bit about how we would look at that and fix it. But just know you need to inspect and see if they have a hematoma. And then legs. So very big one is blood clots. You are at risk being pregnant, number one. Number two, you are put in a bed to have a baby most of the time, right? Especially if you have an epidural, so you're laying still, not doing a whole lot of moving. So we have blood that can pull and cause blood clots. We need to look at the legs, make sure that they're not red, warmth, hot to the touch. They are not edematous. And then also we would check and make sure that they do not have any pain when they like push against our hands, right? And then emotions is the last part of the bubble LE acronym. So this is like your postpartum blues, and then if it persists on to postpartum depression. So feeling a little bit sad and being emotional and having quote postpartum blues is normal within the first few days, and that's just because you have so many hormone changes that are going on. You've also just went through a pretty traumatic experience. Even if you had a good birth, you're also exhausted. You're trying to adjust to being a new parent. You've probably not slept a lot, so that's normal in the first couple of days. If it persists past the first couple of days, then you need to really educate your patient and your patient's support person that they need to call the healthcare provider and get back in to be seen, because they may be starting to head towards postpartum depression. Okay, I know that was a lot. So, is everybody good with all of that information, or is there anything that we need to go back over? Perfect, because this is something that if you are a labor and delivery nurse, you're going to be doing all the time. So it's really pertinent that you know how to do all of these assessments and what to look for. Okay, just a second. I'm trying to find my spot on my paper here. Okay, so it's also super important that you know that you do not have to palpate the uterus, check vital signs every 15 minutes unless you're in that first hour. Okay, so that's the only time that you'll do it after that. And then your provider will write you orders how often to do it. Usually it's every 15 for the first hour, and then it's every 4 hours times two, and then every 8 hours after that. But the only thing that you do all the time in your immediate postpartum period is check your patient's peri pads, look at the lochia, the color, the presence of clots, and then feel the fundus. But it's not every 15 minutes always, okay? It's only every 15 minutes for the first hour. I don't want you to get tripped up on that, okay? Everybody good with that? Perfect. Okay, so what if, let's just do scenarios. What if I told you that you had a patient and it was 3 hours postpartum and she had called you in there and said, "Hey, I have saturated this entire peri pad in like 20 minutes." What would you do? Would you document it or would you say, "This is not okay, we need to call the provider"?
I would say call the provider.
Perfect. So, what if I told you that we had a patient that they were 45 minutes postpartum and they've saturated a pad in an hour? What would we do with that?
That's okay.
That's okay. Yep. Okay. And then we talked a little bit about urinating if they may have problems that can displace the uterus because the bladder becomes distended. So let's talk a little bit about why sometimes that women have problems urinating after delivery. So first off, a problem can be they're swollen, right? Your labias get swollen, your urethra gets swollen. Sometimes it is actually just so swollen that it literally cannot pass urine through it. That's one of the reasons that sometimes they may not be able to urinate after delivery. And then also, sometimes your bladder tone gets reduced. So you may be completely full. Let's say your bladder like literally has like 800 mils of urine in it. And you may not even know it, and you may not even feel like you have to urinate, or you don't feel that urge to urinate. So, pregnancy and then after childbirth, sometimes your bladder tone's just reduced and it you don't feel the urge to urinate. So that's another thing. And that is normal. It can happen. The sensation will come back and you will, feel the urge to urinate, but that is kind of another reason as well if your patient were to ask you that. Okay. Um Another important thing that we need to know. So, remember, we said that some mild cramping is normal after delivery. That's because our uterus is shrinking, it's trying to go back to that pre pregnant size. Sometimes, if we're breastfeeding, that can cause pain as well, like the cramping sensation, because of the natural release of oxytocin. Because we know all that's normal, um, we're okay with it, right? But we still have to assess pain. So I don't want you to go in there and you know, okay, my patient is 24 hours postpartum, they're breastfeeding, they're saying they're having pain and they're cramping. Don't go in there and just be like, "You're fine, you're okay. This is normal. We're just not even gonna worry about it." You still have to assess the pain, okay? So say, where's the pain? When did it start? What's the rating of your pain? Can you tell me the frequency? Is it intermittent? Is it constant? Just make sure you're really assessing that pain, and then that way you can evaluate, is this something new or is this normal postpartum cramps? Okay? Okay. So period and ovulations after delivery. If you are breastfeeding, that is going to affect your period and that is going to affect ovulation. Now, there are some women out there who they breastfeed normal and their kids go to town and they get their period back in 6 weeks. Sometimes it does happen, but most of the time, whenever you breastfeed, your period can take up to a year before it returns. So that can impede your period. If you're bottle feeding, um, usually anywhere around 6 to 12 weeks, your period and ovulation is going to return. So if you have a patient who is bottle feeding, you would want to educate them that their period can return within 6 to 12 weeks. And then if they're breastfeeding, sometimes that it can take a little bit longer and they may not have a period. So if they ask you, hey, when can I expect my period back, or when do I need to try to worry about using some sort of contraception? You either say, hey, are you breastfeeding or are you bottle feeding, right? Because that's a really important question to um, ask so that you know how long exactly to tell them about their period. Okay. Sitz baths. Did you guys read about that in the chapter? Yep. Okay, so sitz baths are really nice for patients, especially number one, if they have a hematoma. Number two, if they just push for a really long time, they're really sore down there, they're really swollen down there. They're just a really nice thing to kind of help them feel a little bit better. And not hurt so bad down there. So sitz baths, they're pretty simple. It's literally just a basin. You put 2 to 3 inches of warm water, not cold, not hot, warm, um, and nothing else can go in it. Okay, so just don't put anything else in it. No soap, no gels, no bubble baths, nothing. Water. That's it. You can put a hot towel, or not hot towel. You can put a towel on the bottom of the sitz bath if it makes them feel more comfortable instead of just like sitting on that basin. And you can do that for about 10 to 15 minutes a day. Okay. All right. This one is like super simple. I don't really know that we need to go over it, but we will. Um, what's the best method to know that your patient has um, understood what you're saying? Teach back, right? So if your patient says, hey, I don't know how to change a diaper, here, let me show you how to change a diaper. You take off the diaper, you wipe them, you put a new diaper on. Okay, can you show me how to do it? Let them teach it back to you. Return demonstration. Okay. In the immediate postpartum period, we did talk about how sometimes baby blues are normal. Um, During that time period, you really want to also observe how your patient interacts with their baby, because sometimes we just have patients who have the normal postpartum blues where they're just, really hormonal and everything makes them sad and they cry. And then we also sometimes have patients who just really hate their baby. They want nothing to do with them. They want to push them to the corner in their bassinet or tell the nurses to come get them and take them to the nursery. So we really want to make sure that we are observing each interaction that we have with our patient, how they are interacting with their baby. And one very important position that you can assess for your patient is called the in face position. So if you see this, this is a good sign. Mom is really happy with her baby. She is bonding with her baby. And you most of the time don't really have to worry about that. So this is kind of where the mom is holding the baby really close to her chest. She has very good eye contact. So they're looking eye to each other. And she's just kind of like gazing at the baby, looking at him, her, whatever, happy, smiling. She may talk positively about the baby. Oh my gosh, he's so sweet. Like, I can't believe that I just had this baby, stuff like that. So just assess and make sure that your mom is really bonding well with the newborn. All right. So uterine atony. Uterine atony is whenever the uterus or the fundus is not staying firm in midline. It becomes boggy, okay? So it's atnus. It does not have a firm shape. There are a couple of things that can cause uterine atony, which will lead to postpartum hemorrhage, right? Because we want our fundus to be nice and firm in midline. If not, we're probably going to have a postpartum hemorrhage. So, um, retained placenta. So after you have a baby, if all of the placenta does not come out and the OBGYN or midwife or whoever has delivered you does not see all of the placenta intact, you can have retained placental fragments. So some pieces of that placenta are still in your body, and that can cause a postpartum hemorrhage and uterine atony. um, Lacerations. So, any sort of laceration on the outside, whether it's an episiotomy or a tear, and then also super, super bad ones, cervical lacerations. So, sometimes when the babies come out of the cervix, they tear the cervix, and those are bad. They will hemorrhage very, very quickly. Um, so, that can cause uterine atony. Any instrumental delivery, so forceps, kiwis, like the little vacuums that are on their head to help them come out, large for gestational age baby, any type of hypertensive disorder, an induction of labor that you're like augmenting them with Pitocin, a very big BMI, and then also over distension of the uterus. Okay. So let's say, oh, and another one, sorry. Prolonged labor. That's a very, very big one, and is usually the biggest cause of uterine atony and postpartum hemorrhage, prolonged labor. So your uterus just gets really overworked to try to get that baby out of there, and it just kind of like tuckers out, honestly. It doesn't really cramp and um, kind of contract to help, keep from bleeding and then also shrink back to that pre-pregnant state. So if you have a patient who's laboring like 18 hours, 19 hours, and this is a lot for them. This is a lot for their uterus. So that can cause uterine atony. Everybody okay with that? Yeah. Okay. While we're on the topic of hemorrhage from uterine atony, so you have a primary hemorrhage and then you have a secondary hemorrhage. Your primary hemorrhage happens within the first 24 hours. A secondary hemorrhage happens after the first 24 hours, but it can last up to 6 weeks postpartum. So, anytime between after 24 hours up to 6 weeks postpartum, you can have a postpartum hemorrhage. That is why it is super important to educate your patient. Hey, if you've went from lochia rubra to lochia serosa to lochia alba, you should not regress. You should not go back to seeing lochia serosa or lochia rubra. If you do, it is very important that you call someone and let them know that you're on the way to the hospital. So, education, education, education with your patients at this point. Another thing that you want to educate your patients on are the 4 T's, okay? So, tone, tissue, trauma, thrombosis. Tone is uterine atony. So, like we said, uterus loses its tone and it can't contract back after delivery, which can cause a postpartum hemorrhage. Tissues, those are things like your retained placenta. So, you have those pieces of placenta fragment that are kind of stuck up in there and they cause postpartum hemorrhage. Trauma, any sort of birth trauma, whether it's a cervical laceration, an episiotomy, a just normal lacerative tear, they've had forceps delivery, a kiwi delivery, and then you have thrombosis. So this is any type of coagulation or a platelet disorder. They can have heavy bleeding from this. Usually it happens within 15 minutes or less if they're going to have a postpartum hemorrhage. Another sign of this would be like constant trickling or oozing of blood. Now, this is something right there. I know we've already learned about this. You have to really decipher from when you are just had that baby, it's just come out of the vagina, and your placenta is separating. We know what trickling and oozing with cord lengthening is normal because the placenta and the cord are coming out. Whenever you've already delivered your placenta and you're in the postpartum period, trickling and oozing of heavy blood, that's not normal, okay? And then anytime that they pass a clot that is larger than a quarter, that is not normal as well, okay? Okay. So all those symptoms are um, indicative of uterine atony, which can lead to a postpartum hemorrhage. So if we have a patient in our room and they ring out on the call bell and they say, "Hey, I just raised up a lot and I just feel like I'm gushing blood," and you go and you pull back the sheets and they are actually gushing blood, what would you do? Do you think that you would let me think how to say this to you. Do you think that you would give a very vigorous and hard postpartum rub to the fundus, or would you just gently massage the fundus until you feel it firm back up?
Gently massage until it firms back up.
Right, because we don't want to cause further damage, right? And are we going to do that fundal massage with one hand?
No, two hands.
No. Right, we're going to put another hand down there on the symphysis pubic bone and we're going to support the uterus so we did not cause a uterine involution. Okay. Hematomas. So like I said, anytime a patient has delivered, if they've pushed for a really long time, they're very, very swollen down there. If they have a laceration of any sort or they've had like an episiotomy, they're at risk for hematomas. So a hematoma, I'm sure you know, is a collection of blood anywhere that it's not supposed to be, basically. So it's outside, kind of like free flowing blood. Your risk factors for the hematoma, like we've said, are episiotomy, laceration, instrumental delivery, anything like that. Signs and symptoms. So your patient may tell you, "I just have a lot of pressure in my vagina and in my rectum, and I just really feel like I need to have a bowel movement, but I can't." That may be something that they tell you, and then you think, "Oh my gosh, okay, I need to really take a look. Let's make sure you don't have a hematoma down there." When you're looking, you're gonna see discoloration. You may see bulging tissue, so that's itself is the hematoma. Um, they may tell you that they feel like they cannot urinate, and that is because of the pressure from the hematoma, depending on where it is. It can put pressure on the urethra. And then also, if it gets big enough, it can actually cause your patient to go into shock. So they can have tachycardia, low blood pressure, anything like that. So, with our hematomas, what we do if we see one, we're going to notify the provider. They're going to tell you most of the time to measure it. Sometimes they'll come in and do it on their own, but they'll probably ask you to do it first. So if it is less than 3 to 5 centimeters, those are the ones that are smaller. We don't really have to worry about those as much. So you're going to put ice on them for 20 minutes every 2 hours for 12 hours. Once that 12-hour period is up, then you can do sitz baths to kind of just help your patient feel more comfortable. Okay. You can also give them pain medication as well because they'll be painful for them. If you measure it and it is larger than 5 centimeters, then unfortunately they're going to have to go to the OR and they're going to have to get that hematoma drained. Okay. Now, nursing care in general for a patient who has a hematoma doesn't matter if they go down to the OR or if you're treating it with ice and a sitz bath. You always want to assess their pain, make sure that they don't have a new onset of pain anywhere or it's, heightened any, and give them pain medication as prescribed. If it is the smaller one, 3 to 5 centimeters, you will do the ice pack every 20 minutes for the first 2 hours. And then you will do the sitz baths after that. And then also monitor for changing in size. So if it is one that you are not going to the OR to get drained, you want to make sure that it is decreasing in size and it's not getting bigger and bigger, because then if it gets bigger, we'll probably have to go to the OR. Okay. Mastitis. Like I said, in the immediate postpartum period, when they are home with you, or home with you, I'm sorry, when they are not going home and they are in the hospital with you, you really don't have to worry about it. Once they go home, that's whenever you usually have to worry about it. Mastitis is caused by Staphylococcus aureus, and it can really happen a lot of different ways. So, if they have any sort of cracked nipples, that is your biggest inlet for mastitis. So let's say the patient doesn't wash their hands before they go to breastfeed the baby and they touch their breast. Well, they're introducing bacteria into their cracked nipples, and that's going to cause mastitis. Then let's also say that they have an improper latch, so the baby's not latched correctly, and they're really tugging on the nipple and causing nipple tears and trauma to the nipples. Um, the bacteria in the baby's mouth can actually go into those cracked nipples as well. And then if they've caused the cracked nipples because they have an improper latch, mom still touches the nipples to draw off the milk or just whatever she's doing, bacteria is going to enter into those as well. It can also be caused by milk stasis, which is what we talked about, um, whenever milk is not getting removed effectively as it should. So that can be caused by improper latch as well. So if the baby's not latching properly, they're not transferring milk effectively. The milk's going to get stuck in those milk ducts. It's going to cause the milk ducts to swell, and they're going to get angry and inflamed and cause mastitis. So that's why it's super important if a mom is breastfeeding, especially breastfeeding, but we also need to assess our other patients as well, bottle feeding, because they still get milk, that we are inspecting the breasts. Now, signs and symptoms of mastitis, you're going to have a red and swollen mass on the breast. They may have pain or burning in general, but then especially when they're breastfeeding, they're going to complain of it really, really hurting bad. The skin's going to be red. They're going to have malaise and flu-like symptoms, so fever, fatigue, malaise, all of that. And then just breast pain as well. Even if they're not breastfeeding, they're going to complain of pain. So we always want to teach our patients, always wash your hands before you even touch your breast to breastfeed. You as the nurse are going to observe a feeding, and you don't have to be cruel about this, because sometimes in that immediate postpartum period you have patients who just want to breastfeed so bad that that's all they think about. Okay, they want to do it, they're bound to determine, and it absolutely kills their soul if they think they can't or they're not doing it correctly. So you may go in and just say, hey, when did the baby eat last? Okay, how long have they been going in between feeds? Okay, do you mind if I come in and observe just to make sure everything's going well? And then you'll go back at the next feeding and just say, hey, okay, you do your thing, and I'm going to sit and watch you, and just make sure that everything feels okay with you. If you feel like you need any help, please just let me know. And then you can also just say, we do have lactation here. If you feel like you need to see them at any point, please just let me know. We can get a referral put in for you. So kind of be really supportive with it, and kind of like put it off to them as you're not already thinking that they're doing something wrong. But make sure that you're observing, and make sure that the baby has a very good wide open mouth. They're getting all of that nipple and most of the areola from the bottom up to the top in their mouth. You should still see a little bit of areola left on the top, and they are swallowing. So that is another big thing that you want to look for to make sure that they're getting milk. You'll see them, they'll kind of like suck, 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 swallow, suck, 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 swallow. So you really want to make sure that they're getting a swallow in there so that they have a good latch as well. Make sure you're educating them to feed regularly. So feeding on demand is very important. So even if the baby has just ate 5 minutes ago, they may be cluster feeding. So we want to educate them that you still put the baby to the breast. Watch for the baby licking its lips, sticking its tongue out, eating on its hands. Put it to the breast regularly to prevent milk stasis and make sure we're getting that milk out of there. And then if they end up with mastitis, they will be on antibiotics. We want to encourage them to take the full course of antibiotics to make sure that they are completely eradicating that Staphylococcus aureus in there. And then they can also do a warm compress to the breast. This is going to help with discomfort, but the heat can also help to open up the milk ducts and help the milk to kind of flow out a little bit better, because it decreases that inflammation in there, and that'll get rid of our milk stasis if that's the problem, and help us to hopefully also eradicate mastitis as well. So if we have a patient and she's called back into the unit after she's went home and she's like, hey, I'm just really not feeling good. I had a baby like 15 days ago. I'm having a fever, I have malaise. I'm breastfeeding, it's hurting really bad, it's burning, we would say, hey, that's probably mastitis. You probably need to go to your provider and get checked out, okay? Because you're going to need antibiotics. Okay. Do you guys know what involution and subinvolution is? Yeah. Who raised their hand? Or was it accident?
I'm sorry, that was an accident. I didn't mean to. But
Oh,
if you wouldn't mind going over that, I'd appreciate it.
sure.
Is it
Okay.
where like the uterus or whatever doesn't go back like it's supposed to?
Yes. So involution, think about this, is normal, right? It's normal to have involution of things. So involution is great. That's what we want. And that is your uterus returning to a pre-pregnant size. Subinvolution, that is not what we want. So that means the uterus is delayed or it is not going back to its pre-pregnant size. Pretty much self-explanatory on that one. It's more of just like a term thing. So just know the definitions of involution and subinvolution. Your 4 T's. So we talked about that already. The tone, trauma, tissue, and thrombosis. We've already went over that. Remember, at the first hour, your uterus should be palpated, or your fundus should be palpated at the umbilicus, and then every day after that, it should descend 1 finger breadth or 1 centimeter a day, and then by day 10, it should be subinvoluted, right, back in, or not subinvoluted, involuted back into the pelvis. Okay. So what if you have a patient and you are doing a postpartum check on her? You're rubbing and trying to feel for a fundus, but it is boggy and it's displaced to the right, and you palpate a full bladder. What would you ask your patient to do?
Ambulate to the restroom.
Yep. Perfect. Just a second. I'm just trying to make sure that we covered everything on here. Okay, you guys know the signs and symptoms of a DVT, right? Unilateral calf pain, redness, warmth, swelling. All of those are signs of DVTs, and that is a part of your bubble LE mnemonic. So leg, we want to make sure we're inspecting the leg. There's no red streaking areas. There's no edematous areas. They're not having unilateral calf pain. That can be indicative of a DVT. If your patient has a DVT and it has dislodged and it has become a pulmonary embolism, then that is, your patient may complain of dyspnea, so shortness of breath, trouble breathing. They may have chest pain. They may become tachycardic. And then also remember, for med-surg pulmonary embolism, they can have hemoptysis, so like pink tinged sputum, okay? And then just really educate on postpartum depression. So like we said, the first couple of days, if they're crying and they just feel overwhelmed and they're just having the baby blues, that's okay. If it persists after that, then it may be postpartum depression, and we may worry about them and tell them they need to call a healthcare provider and get back in to be seen. You also want to educate the patient and the partner if they have any sort of like suicidal ideations or anything like that, or if they're that person that just really cannot stand their baby during the postpartum period. You never want to either leave the patient alone or leave the patient alone with the baby if they're having those issues. Take the baby somewhere to a safe room, call for help, and get the patient to where they can get help, okay? Because that's nothing to play with, because postpartum depression could turn into postpartum psychosis, and that is whenever they will act on whatever ideation that they have. So that is about everything on there. Do you guys have questions about anything? Or we need to go back over anything? Because I'm good to do that as well.